Hi, everyone. My name is Rachel Komitsky. I am the rep over in the Manhattan office for our Rothman physician. So tonight I will be moderating. So thank you again for everyone for joining us. Today we will be recording this lecture and send it out to all of our registered guests. So if there is any connectivity issues or you don't hear something, don't worry, we will be sending this to your computers. So today's virtual lecture will be given by Dr. Brandon Erickson. So Dr. Erickson is a board-certified, fellowship-trained orthopedic surgeon specializing in sports-related injuries of both athletes and non-athletes alike. He's completed his residency in orthopedic surgery at University Medical Center in Chicago, followed by a sports medicine fellowship at the Hospital for Special Surgery in New York. During his fellowship, Dr. Erickson served as one of the assistant team physicians for the New York Mets. Dr. Erickson is also a New Jersey native and played football for University of Notre Dame as a wide receiver. As an athlete himself, Dr. Erickson's goal is to get patients back into the playing field while utilizing the most advanced treatment and options. While Dr. Erickson treats athletes of all levels, high school to college to professional to those weekend warriors, he also specializes in non-athletic conditions on the shoulder, elbow, and knee. In addition, he's been named one of the Castle Connolly top doctors. Dr. Erickson sees patients in our Manhattan, Harrison, and Tarrytown offices. Tonight's lecture, again, will be discussed by Dr. Erickson. We're discussing comprehensive reviews of the meniscus tears. If there's any questions throughout the lecture, feel free to ask in our Q&A section at the bottom of the screen, and Dr. Erickson will answer them at the end of the presentation. I'll now turn it over to you, Dr. Erickson.
Excellent. Thanks, Rachel. So I'll share my screen here. Certainly feel free to type questions into the chat box at the bottom. I am down in Clearwater now at spring training for the Phillies, and there is a guy that I'll have to take a look at some point during this lecture, so I apologize if we have to pause for a minute. So we'll get right into this. So we're going to talk a little bit about meniscus tears today. These are my disclosures, not particularly relevant to this talk. And so the real question is, why are we even doing this? What's the purpose of this lecture? Why are we talking about meniscus tears? And so I think to understand that, we have to understand a little bit of the background and anatomy of the knee. And we won't dive into this too much, but sometimes this can be helpful if you have a baseline understanding of this. So when we think about the knee pain is one of the most common things that I see in the office. And there's a lot of different things that can cause pain in your knee. Sometimes you have an issue with some muscle or a tendon. Sometimes you can have a tear in the meniscus, like we're going to discuss tonight. Sometimes you can have a problem with the cartilage, which is the glossy stuff on the end of the bones. Sometimes you can have a bone problem, like a little bit of a cyst that can cause pain. Sometimes the nerves can get out of whack, and that can cause some pain in the knee. Or you can have a blood supply issue, or you can have a problem with a ligament. And you can tear things like your ACL or your MCL. So there's a lot of things that live around the knee that can cause pain and discomfort. And so figuring out which one it is can sometimes be a little bit challenging. So if you think about cartilage in the knee, there's actually two types of cartilage. One of the types of cartilage is what's on the end of your bones. It's what's called articular cartilage. In that picture that you see on your right there, it's that really white, shiny stuff. And when you're born, that is very, very smooth. And over time, it starts to wear down, it starts to thin out, and you can get those little almost cracks and potholes like you see in that picture there. The other type of cartilage is what's called fibrocartilage, and that's actually what makes up the meniscus. So even though the meniscus is different cartilage than what's on the end of your bones, it is a type of cartilage. And the meniscus really functions like a shock absorber, and we'll go over the functions of the meniscus in a second. Now, that cartilage on the end of the bone, the real purpose of that cartilage is to create a nice, smooth, gliding surface for your knee to be able to bend and straighten. And it decreases the amount of friction that's there between the bones, and it also protects the bone from any wear, because without the cartilage, then the bone sees all of the load in your knee, and that becomes a problem. And you can see that's the meniscus down there, and this is the area of wear of the cartilage. When we think about the meniscus is a little C-shaped shock absorber, and you have one on the inside of the knee and one on the outside of your knee. The inside of the knee is called the medial one, the outside of the knee is called your lateral one. And in this arthroscopic picture here on your right, that's what it looks like inside your knee joint. Your thigh bone's on the top of the screen, your shin bone, what's called your tibia, is on the bottom of your screen, and that round kind of C-shaped looking thing, that's your meniscus, and that's my little shaver that's on top of that, kind of just so I can pointing it to you so you can see it. And the meniscus has a couple different functions. First of all, it functions to cushion and protect the cartilage surfaces in your knee. So while I talked about the cartilage protecting the bone, the meniscus helps protect the cartilage surfaces. It also actually helps lubricate your knee. So there's a little bit of fluid that actually should live in your knee. Think of it almost like WD-40. We want to have a little bit of fluid in our knee. We don't want to have too much fluid in our knee. And that's what happens when we have a flare-up of arthritis, or if we tear a ligament, then the knee can swell up a lot, and that can cause a problem. But a little bit of fluid in the knee is a really good lubricant. We like that. The meniscus actually also gives you a little bit of stability to the knee. So we always think of the ligaments of the knee as providing our stability. Everybody always thinks of the ACL, which is certainly a very important stabilizer of the knee. But actually, the meniscus works in concert with the ACL to do a couple things to provide stability for the knee. And then it actually also helps provide you some proprioception, or kind of understanding where your knee is in space. So it actually does a lot of different things, not just cushioning the knee. And then if we think about who potentially gets meniscus tears, there's two real types of meniscus tears. We have the kind of acute traumatic tears that people get. Usually this is younger patients, but not necessarily. And it usually happens from a twisting or a pivoting injury or slipping down the stairs. And this is the type of tear that oftentimes causes mechanical symptoms. Sometimes it can cause the knee to get stuck or locked. Sometimes it'll make it so you can't fully straighten your knee when you could before. And those are things that clue us into potentially having a meniscal issue. And then we have the non-acute or the degenerative type tears. And these are the ones that happen kind of attritionally over time, usually in older individuals. Sometimes if you had a prior knee surgery, this can lead to these degenerative tears, because what can happen is you start to lose the cartilage surfaces on the end of the bones, and the bones start to become exposed. Then they start to grind down the meniscus a little bit. And so that can start to lead to some fraying and some issues with the meniscus. And the reason this is relevant is because sometimes we'll treat these differently. We'll get into treatment in a little bit here. Now, from a diagnosis perspective, right, obviously we want to make sure that you actually have a meniscus tear. So how do we decide whether or not you have a meniscus tear? Well, when usually people come into my office that had meniscus tears, there's a couple things they usually tell me, and this isn't true for everyone, but this is kind of a rule of thumb, if you will. Usually they have pain either on the inside, the medial, or the outside of their knee. And this pain is usually in the area where the meniscus is. And so when they point to the knee, they say, yeah, it hurts on the inside over here. And they'll point right over where the meniscus is. Usually there'll be some swelling, but it's not usually dramatic to the point where the knee is blown up like crazy. It's usually a little bit of swelling, and sometimes it limits their motion, but it's usually not dramatic. And then occasionally people will tell me that they're having some mechanical symptoms. And by that, I mean some clicking or some catching. Occasionally, like I said, the knee will lock, but usually there's a click that's present in the knee, especially when they twist and pivot. And when I asked them, I said, when does your knee hurt? Is it when you go up and down stairs? Is it when you change direction? A lot of times people that have a meniscus tear that's causing symptoms in their knee, usually it hurts when they twist or pivot. It'll hurt when they get into and out of a car, when they roll over in bed at night. Usually doesn't hurt quite as much when they're going up and down stairs, because sometimes pain going up and down stairs can be from some wear and tear of the cartilage behind the kneecap. Not to say a meniscus tear can't hurt you with that, but oftentimes if you tell me, yeah, I have no pain with rotation, I have no pain getting into and out of a car, it just hurts me when I go up and down stairs, even if there is something going on with your meniscus, that's probably not the thing that's causing the pain with you going up and down stairs. It's probably more a little bit of wear and tear of the cartilage behind your kneecap. And then, of course, I do an exam on you. And usually when I examine somebody who had a meniscus tear, they hurt over the meniscus, which is what you see here on the bottom. These are kind of my thumbs pushing over somebody's knee, and that's the area where it tends to hurt when you have a meniscus tear. And then there's a couple of special tests that if you've ever seen me in the office, I do. It's where I kind of rotate your knee and crank on it pretty good and see if you start to either have a click or some pain. And oftentimes, if you do, that's an indicator that you may have a meniscus tear going on. And so everybody that comes to see me in the office gets a set of x-rays. And a lot of times I have patients ask me, why are we getting x-rays? I didn't break anything. Well, that's certainly true. X-rays can definitely tell us if you have a broken bone, but it also tells me about the alignment of your knee, and it also tells me if you have any significant arthritis in your knee. I can't see the meniscus on an x-ray. I can't see your cartilage on an x-ray. But what I can see is the space between the bones, and I can see if you're starting to form any extra bone, as we sometimes see in arthritis. So if you take a look at this person's knee here, the picture on the left, that's looking at you straight on. And so there's the inside of the knee and the outside of the knee, which has an extra bone on the outside. And you can see there's still pretty good space between those bones. And then we look at the kneecap view, which is on the right side. So that's the kneecap and the groove that it sits in. And there's still good space between the kneecap and the groove that it sits in. Conversely, if you take a look at this x-ray here, you can see that there's a lot less space in between the bones on the inside of the knee compared to the outside of the knee. And when we start to see this, if you notice here, this is the outside of the knee, this is the inside of the knee, and you can see it's really not the same there. And when we start to see those bones starting to touch like this, these people oftentimes will have a tear in their inside meniscus, but they're also going to have significant arthritis on the inside of the knee. And sometimes it's really not the meniscus that's causing that pain. It's really that early arthritis in the knee that can be causing the pain. And sometimes it's hard to differentiate between the two. So once you've said, okay, you've come in, you have some pain with rotation and maneuvers, you have pain when I push on your knee, some of the provocative tests are positive, we think you have a meniscus tear. So how do we treat these? How do we get you better? Well, it really depends on how much the knee's bothering you and how bad your symptoms are. So if you say to me, listen, these symptoms are pretty manageable, they're very mild, it bothers me from time to time, it's not limiting me, my knee's not getting stuck, then a lot of times non-operative or non-surgical treatment is the route to go. And what I mean when I talk about non-surgical treatment is oftentimes we'll try a steroid shot in the knee, which will help quiet down the inflammation. We don't do this as a repeated thing, but a one-time steroid shot's a really good tool to help knock the inflammation and the pain level down in the knee. And then we usually start a course of physical therapy that focuses on quadricep strengthening, core strengthening, hamstring and IT band stretching. And that helps to take some stress off of the knee joint itself. If you think about your leg and you think about what puts stress on the knee and what takes stress off the knee, when you're putting your weight on your leg, obviously your full weight's going on your knee. And if the surrounding muscles aren't supporting the leg properly and they're not taking weight off of the knee, then the knee sees quite a bit of stress. If those muscles are firing well, they can sometimes take a little bit of stress off the knee. And so that can sometimes help people that have knee problems to really start to feel quite a bit better. And then there's other things we can do. We can try things like gel injections, like PRP, but we oftentimes hold on those because they're usually not kind of our first line of treatment. They're usually a second line of treatment going down the road. And the reason I mentioned the gel injections is because sometimes people that have meniscus tears, especially the degenerative ones, will have some amount of knee arthritis. It may not be a significant amount, but sometimes there's some underlying arthritis in the knee. And so it's hard for us sometimes to parse out, is the arthritis causing the pain or is the meniscus tear causing the pain? And we have to try to treat specific things in the knee to help with that pain. And one of the things we can use to help with that pain is the gel shots, because if you look at some of the studies that are out there, the gel shots tend to do a pretty good job of helping people that have pain that's coming from knee arthritis. What the gel shots are, think of them like a lubricating injection, almost like WD-40 for the knee. They help things glide a little bit smoother. They don't repair your cartilage. They don't repair meniscus tears. They don't do things like that. But they're functioning basically to help protect whatever cartilage is there and also to help lubricate the knee. And what we've seen in the literature is that usually these shots will last somewhere around 6 months. Some people can get more benefit, some people get less benefit, but oftentimes this will help people's pain that have pain that's coming from arthritis. So if you have a little bit of arthritis and you have a meniscus tear and we give you a round of gel shots and your pain gets significantly better, then probably your pain was coming from the arthritis and not from the meniscus tear. If we do a round of the gel shots and you really get no improvement from it, it could be that you're just a non-responder to the gel shots, or it could be that the meniscus tear is really what's causing your symptoms. And then we have to think about other treatment options. So let's say the initial round of treatment options that we do don't work, and we're still presuming that you have a meniscus tear. Well, how do I definitively diagnose a meniscus tear? Well, I have to get an MRI in your knee because an MRI tells me all about the soft tissues of the knee, tells me about the cartilage, tells me about the meniscus, tells me about the tendons and ligaments. And so this is what an MRI looks like when we get this on somebody's knee. And these are a couple still shots just to go over it with you. And so if you look at that picture on the left, what it shows me is it shows me your thigh bone, which is labeled F for femur. Then it shows me your thigh bone, your tibia, which is your shin bone, which is labeled T. And then on the back of the knee here, where this big red arrow is, this little black triangle looking thing, that's the meniscus in the knee. And what you'll see is there's a big white line that goes through that meniscus. Usually this should look like a nice, thick black bow tie here. You shouldn't see this line going through it. That line is the tear in the meniscus. And if you take a look at the image on the right, again, this is a different way to look at it, but you can start to see this little black triangle looking thing here. Again, that's the meniscus in the knee. So we can see a tear in the meniscus on the MRI, but more importantly, I can also see your cartilage, which is this gray stuff on the end of the bone here. And when that looks really healthy and you have a tear in the meniscus, then I'm pretty positive that your symptoms are coming from that meniscus tear. So let's say you have a meniscus tear. We've tried the conservative management. We've tried the steroid shot plus minus the gel shot. You've done the therapy. You're still not happy with where the knee is. You're still having some mechanical symptoms and it's not in a good place. Well, then we have to talk about other treatment options. And this is usually talking about a surgery. And there's two ways to treat meniscus tears surgically. So option one is we do what's called a meniscectomy, where basically we go in and we clip out the piece of the meniscus that's torn. Think of it like clipping a hangnail. So when you tear your meniscus, the reason you have pain in the knee is because the meniscus surface is no longer even. So you have these frayed pieces, and the frayed pieces can rub up against the cartilage and it can irritate it. And sometimes people that have meniscus tears, when they're just walking along, it doesn't really bother them. And when they twist the knee and they irritate where that tear is because the tear banks into the cartilage, that causes them some pain and discomfort. Similar to if you had a hangnail on your finger, it does okay sometimes. And then when you hit it the wrong way on the desk, it starts to cause a lot of pain. So what you do with a meniscectomy is, or simple knee surgery is, you go in and you basically clip off the piece that's torn and you leave the rest of the meniscus alone. So you only take out the piece that's torn. Think of it again like clipping a hangnail. And we do this for the smaller type tears. Now, the other thing you can do is do what's called a meniscus repair, where I fix the meniscus tear. And this is usually done in larger tears where we use sutures to basically repair the piece of the meniscus that's torn. And you may say to me, well, even though I have a small tear, why don't you fix the small tear? I don't want to lose any part of my meniscus. Well, there's a couple reasons for that. The first reason is it's a much longer recovery if we do a repair than if we do a meniscectomy. So if you have a very small tear, it doesn't usually cause a huge problem if you take out that small piece of meniscus, and to put you through a rehab to repair it is a big deal. But more importantly, the reason we don't fix the very small tears is because you can't. They won't heal. So the blood supply to the meniscus is not very good. It's why you see so many people that get meniscus tears, because it's an area where the blood supply is not very robust. And so if you think of that meniscus like the C that we talked about, towards the outside of that meniscus, the blood supply is pretty good. And as you start to creep in, where my little biter is in this picture over here, the blood supply to that area is very poor. And so if you try to put stitches through that area, it won't heal and it will re-tear, and you wind up having to undergo two surgeries. The first one to try to fix a tear that shouldn't have been fixed in the first place, and the second time a meniscectomy where we basically clip out the piece that's torn. Now, again, in those bigger tears, we're fixing these all the time. We're not taking out your whole meniscus, but in those smaller tears, we go in and we just simply remove the piece that's torn. Now, let me walk you through a little bit of what to expect if you have that surgery. So if you think about the one where we go in and we clip out the piece that's torn, okay? This is an outpatient procedure. You come and go home the same day, okay? You get two small poke holes that are around your knee about the size of your fingertip, okay? The surgery for this only takes about 10 minutes, give or take. And what we do is we go in arthroscopically with our little camera and our little instruments, and we look around your whole knee. We take a whole bunch of pictures. We look to see if there's any issues with the cartilage and other spots of your knee. We look to see if there's a meniscus tear on the inside, the outside. We look at your ligaments inside the knee. And then we get to work on the area where the meniscus is torn. And we use that little shaver that you saw, as well as that little biter that you saw. And we basically just remove the piece that's torn. You can put full weight on this the same day if you're comfortable. So you can use crutches if you want to, but you don't have to. Okay. And then usually after a week or so, we start physical therapy. And usually you're in therapy for about a month, give or take. And to get back to running and sports and things like that is usually about 6 to 8 weeks after this surgery. And so while you're not better the next day, you start to see improvements in your symptoms pretty quickly. And then we have to work with physical therapy to build up again the supporting muscles around the knee, because chances are, because you've been dealing with this pain for some time, those muscles have gotten a little bit weak. So we have to build them back to where they're supposed to be to get you back to a good place. And this is what it looks like when we do a meniscectomy. So the picture on the left there, that's looking at somebody's knee. Again, the top of this is your thigh bone, the bottom of this is your shin bone, and this thing is the meniscus. And you can see this area right in here where their meniscus is torn. And you can imagine if you're trying to put weight on that, that tear is just knocking into this bone. It's not a smooth edge, and it starts to irritate the knee quite a bit. And then after we do the meniscectomy, we simply clean that piece up, and now we have a very nice smooth edge. You see, we haven't taken much of the meniscus out at all. We've just taken the piece that's torn, and we've contoured it nicely so that now when you put weight on that leg, it's not going to impact you, and the meniscus will function well, and it'll help protect the cartilage again like it's supposed to. Very different if we're going to do a meniscus repair. Okay, so that was the one where we go in and we just clean up the tear. If we're going to fix the tear, the rehab is a lot different, okay? It's still an outpatient procedure. You still get two small poke holes around the knee, and sometimes you'll get a little incision on your leg, depending on the type of meniscus repair that we have to do. And this surgery takes about twice as long. It's more like 20 minutes to get this. But for this one, I have you not put any weight on that knee for the first 2 weeks. And then after we get past the 2 week mark, we start putting some weight on the knee over the next 2 to 3 weeks, and then get you back to full weight bearing on it. You still start therapy after about a week, but for this, you're usually in therapy for more like 2 to 2.5 months. And if you're thinking about full return to sport, that's somewhere between 4 and 5 months after the surgery. So it's a much longer recovery. And we do this in people who need this done, right? We don't just repair everybody's meniscus. We do this when you have a tear that, one, is repairable, and two, is in an area where we think it's going to heal. And so this is what an MRI looks like sometimes of somebody who tears what's called their root. Now, we didn't talk about this before, but the root is the attachment point of the meniscus to the bone. So if you can imagine, if you tear the attachment point of the meniscus to the bone, it really is very unstable and it can't do its job. So we have to restabilize that. So this is a type of meniscus repair that we do. And this is what the surgery looks like here. So this is with the camera in somebody's knee, looking at their knee, and you can see my little probe there is under the meniscus. Now we drilled a tunnel up in their bone, and we passed a suture up through that tunnel because we're going to repair this meniscus back down to the bone. And then we use this little fancy tool where we pass a stitch that goes through the meniscus tear, and we almost make a little luggage tag around that meniscus tear with the stitch, which you'll see a little bit better in a second. You can see we're working in kind of a tight space here, but you'll see as I pull the camera back in a second, you'll see what this luggage tag looks like. And then we put a second one in to really reinforce this. So that way we have 2 points of fixation on the meniscus before we have to dunk it back down into the bone. And so once we have these sutures through and we feel like we've done a really nice job capturing that meniscus, you can see that piece is completely floppy because it's completely torn off of the bone. And if we hadn't fixed this back, it would stay floppy and cause quite a bit of symptoms. So we have these 2 stitches passed, and then what we do is we shuttle them down through that tunnel that we drilled before. So we'll back the camera up in a second so you can kind of see what the tags look like. So those are the 2 luggage tags there. And then what we do is we'll shuttle them down through that tunnel that we drilled. And this one I actually put a 3rd stitch in just to give a little extra support. This was in a younger person. Sometimes these root tears happen in a little bit of older people, but this was a younger person who's really, really active. And so I was worried that he was going to be a little bit of a knucklehead after this. So I did this to basically protect him from himself. And so we're able to get 3 stitches in there. Sometimes you can't get 3 stitches in the tear, but in him, we were lucky and we were able to fit 3 stitches in it. And then you'll see I'll shuttle these stitches down through the tunnel that we drilled back where the meniscus is supposed to attach. And then we pull them down and we reattach the meniscus to the bone by putting a little anchor into the bone, into your shin bone, which holds those sutures in place. And so that's what it looks like once we repaired this. We've anchored that nicely back down to the bone. That's kind of the final picture there. And then we actually poke some holes in an area of the knee where you don't need the cartilage to basically let some stem cells come out into the knee to try to help this to heal. So I wanted to leave enough time so we could go over some questions and things. A couple of patients that have seen me mentioned they had some questions about this, but I want to just kind of summarize in saying that, meniscus tears are really, really common. Again, the blood supply is not great. They happen with degeneration over time, and they can happen acutely. Okay. A lot of times these will get better on their own. And so we try simple things like steroid shots, like physical therapy. We try to get these better if we can with those types of things in the right person for those tears. If somebody's 20 years old and comes in and has an acute injury to their knee and has a huge meniscus tear that needs to be fixed, we don't go down the steroid and physical therapy route. That has to be fixed. But in most patients that come in with meniscus tears, usually a trial of that conservative or non-operative treatment does pretty well. And sometimes that can be a long-term solution. If those things don't work, or if there's other circumstances we have to address, then we wind up getting advanced imaging, we get our MRI, and then you and I have a discussion of whether or not we think a meniscus repair or a meniscectomy is the right surgery for you. And then we execute the surgery, and then we have you execute the physical therapy afterwards to make sure that we get you back to having a knee that you really like. Recovery from surgery obviously depends a little bit on whether or not we take a piece out or we repair it. Again, it's a couple-month difference in recovery. And the other thing, as I mentioned before, is if you're one of the people that has a meniscus tear but also has some arthritis in the knee, we really try our best to get that better with the steroid shot and the therapy first. Because even if I go in and take care of the tear in the meniscus, sometimes if you have kind of moderate arthritis, you'll still have some arthritis pain afterwards. Now, whether that's 10 or 20% of your pain or 70 or 80% of your pain, we don't know until we take care of the meniscus tear, but we try to, if we can, get those type of patients, you patients, better without surgery if we can, because we know that there's going to be some residual pain from the arthritis in the knee down the road. So with that, I'm happy to take some questions. We have a website that'll be up and running in a couple of weeks, so feel free to visit our website. These are my girls who are at home now. My poor wife is watching my three-year-old and my 3-month-old by herself. And I've not been sleeping for her very well as I've been down in Florida for the last couple of days, and I'm here until Friday. So everybody just say a quick prayer for her.
Well, thank you so much, Dr. Erickson. That was so beautifully told. And thank you for sharing, the pictures of your beautiful family, and God bless your wife, right? For sure. So
Yeah.
with that, we did get a few questions from the chat. For anyone I didn't respond to yet, we're going to get to those now. So I'm just going to go from the top of the list and run down if that's all right with you.
Yep.
Cool.
Throw it at me.
Wonderful. So the first one we had was, can a meniscus tear heal on its own?
Yeah, great question. I get it all the time. They do not heal on their own. So the reason that they don't heal is because every time you take a step, you're compressing and rotating on that tear. And so you're not giving the tissue a chance to heal. In addition, the blood supply of the meniscus is not really good. And so if you're trying to get something that has a very poor blood supply that you're constantly irritating to heal, and it just doesn't happen. And so people ask me, I've had PRP injections, or I've had gel shots, I've had this. they're all things to try because they help manage symptoms, but nothing outside of me physically going in and surgically operating on the tear is going to fix it. Now, that doesn't mean everybody that has a meniscus tear needs to have surgery. It just means that in order to actually definitively fix the problem, you have to have a surgery to fix it.
Wonderful. Thank you. The next question actually kind of aligns perfectly with what you were just saying. So, how successful is PRP? I've had it one time. Insurance did not cover that, so I did not want to try a second time, even though it was suggested.
Yeah. PRP again is for symptom management with this, right? And so the issue with PRP, of course, is that no insurance company covers it, right? I like PRP as an injection. I think it's great. But it's expensive and it's not treating the root cause of the problem. So as long as you understand that the goal of PRP is to treat the symptoms that are coming from the problem, it's completely fine to try it. And if money is not really a big issue for you, you can try them as many times as you want because it's not toxic to the knee. If you tried one PRP shot and you notice that it didn't really get you to where you want to be, I don't know that wasting another 12 or 1500 bucks on a PRP injection is really the best thing for you. I'd probably try something else outside of that, whether it's the steroid or the gel, or whether it's a knee scope like we talked about to fix the problem. I'd probably start going down that route. But again, PRP is not toxic to your knee, so you can do it as much as you like. It's just it becomes cost prohibitive at some point.
Wonderful. Thank you. The next question is, can you discuss treatment for Baker's cyst when they develop in context of meniscus tears / arthritis?
Yes, let's talk a little bit about Baker's cyst because I get this question quite frequently. So a Baker's cyst is basically some fluid that leaks out in the back of your knee, in between a weak spot, in between two of your hamstring tendons in the back of your knee. Your knee has this thing called a capsule, which is a water balloon that goes around the knee. It helps keep the fluid inside. And when your knee swells up, whether that's from some irritation from the meniscus tear, some irritation from arthritis in the knee, whatever caused your knee to swell, the fluid sometimes will leak out the back of the knee. Now, the problem with that is it's a one-way valve in the back of the knee. So the fluid usually doesn't decompress itself and come back in. Sometimes those Baker cysts will pop and the fluid will go down your leg and you'll feel some relief in your symptoms and your leg will swell up and get bruised. And that's okay. That's totally fine. It doesn't cause a problem. But the Baker cyst is a result of a problem that's happening inside the knee. So you can drain a Baker cyst, which will take the fluid out of it, and that has to be done under ultrasound guidance. My partners do them, Dr. Rubish, Dr. Gonzalez, depending on if you're in New York or Westchester or Dr. Chang. That has to be done under ultrasound guidance because you can't just stick a needle blindly into the back of the knee. I can put a needle inside your knee from the front without an ultrasound, but from the back, there's a lot of blood vessels and nerves that live back there. So that has to be drained with an ultrasound. And so you can drain it, and that will manage the symptoms from the Baker cyst. It'll get the Baker cyst to go away. But if your knee swells up again because of the problem that you haven't addressed inside the knee, the Baker cyst will probably come back. So the way to get a Baker cyst to really stop coming back long term is to take care of the thing that's causing the Baker cyst, which is the thing that's causing the swelling in your knee, which could be arthritis, which could be a meniscus tear. So definitively taking care of those will get rid of the Baker cyst.
Thank you. The next question is, what is the best day-to-day treatment for a meniscus tear that isn't severe but can get problemsome if it gets worse?
Yeah.
Is it continuing to exercise like walking, Pilates, gentle yoga, or is it by doing nothing?
Yeah, so I always tell people motion is lotion, right? The more you do, the better, right? I want you to move. Moving is better because if you don't, the knee will stiffen up. It's a problem. That's exactly what happens with meniscus tears, is that usually they're okay, and then you do something to irritate that hangnail, and then it starts to flare up on you. And then you quiet down what you're doing for a couple days, the tear quiets down, you feel better, and then again, you go back to doing something and it irritates the tear. If you're finding yourself getting into that cycle, right, we should try something to treat that. We should either try an injection, we should try some therapy, or we should just take care of the tear because you're probably going to have a hard time breaking that cycle without that. But that's exactly how people who have meniscus tears and it's been bothering them for a while, that's what they tell me, that's how they present. Just so you see, this is super fancy water. This is from some volcano in Hawaii. I don't know. The Phillies have all kinds of funky stuff down here.
Does it taste any different?
Tastes like water.
Delicious. There you go.
Yeah,
But nice
tastes like water.
packaging nonetheless.
Tastes like water.
So the next question is, how long and how much cortisone can be used for pain? When does it become counterproductive?
Um, so here's the deal with cortisone. Cortisone injections are a really, really good tool to use. Too many cortisone injections over a long period of time can lead to arthritis. So if we're talking about somebody's knee, if you don't have arthritis in your knee, we don't want to do too many cortisone shots in your knee. 1 or 2 is really all we really want to do if you don't have arthritis. If you have arthritis, well, then it's not that big of a deal because the downside of the cortisone shot is that you get arthritis. Now, you can get infections, of course, if you give too many of them. But if you have arthritis and we're really managing more arthritis symptoms, you can get 3 cortisone shots in that knee basically per year. And so we can manage your symptoms like that if it's working, if you want. But we only do that if you have significant arthritis in your knee.
Thank you. Just a few more. How frequently do you need to repair the meniscus when the initial surgery was going to clip off a small tear?
So usually that's very rare. So I always tell people who I think there's a chance that need a repair, I go over both therapy protocols with them because the MRI is a good test, but it's not perfect. And when I get in your knee, I'm going to make the right decision for your knee. So I like to try to prepare you beforehand. If I think there's even a possibility that it's going to be a repair, I go over that with you beforehand. So we talk about the difference in rehab protocols. If we don't talk about fixing the tear, there's a very, 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 very low likelihood that I would have to fix that if I went in thinking I was going to have to clip it out.
Thank you. Next question is, can obesity be a cause for a meniscus tear?
Um, Obesity can lead to increased, or obesity does lead to increased pressure in the knee. So the more weight you have on your body, the more stress the knee sees. That can absolutely contribute to having meniscus tears. The problem is if you are obese and we go into your knee and we scope it and we clean up the meniscus tear, there's still probably going to be some wear and tear in your knee just from some early arthritis from having the added weight on the knee. So it's a little bit of a hard decision to make because you don't do quite as well after surgery from that. So we try our best to not have to operate on those types of tears.
Thank you. This is actually from a previous patient of yours. So it says, tell me more about torn meniscus with arthritis. That's me, I think. I don't want surgery. I've had the cortisone shot and I've done PT for about 6 months. I'm better, but the pain has not gone away. There's still swelling in a new spot.
Yeah. I mean, so certainly if we're thinking that we don't want to try the surgery route, then I would try the gel shots. And if that didn't get you there, that's when I would say maybe we try a PRP injection and see if that gets you there. Because if there's only so many things I can throw at meniscus tears, right? I can throw therapy, I can throw injections, whether that's steroids, gel, or PRP. And then I'm kind of out of options, right? So there's only so many things we can exhaust, and we can try them in different combinations and permutations. But that's kind of what we have in our arsenal.
Wonderful. And just letting everyone know, if you do need an appointment, I will be sure to share my information. I can facilitate that pretty easily with same and next day appointments, obviously when Dr. Erickson is in the office and available, but just wanted to put that out there. So thank you for your question. Just a few more. The next one is, what are the best treatment options for an articular cartilage injury in the knee? Surgery, question mark, PT, question mark?
Depends on what the cartilage lesion looks like. That gets into a little bit of intricacies. So if it's a very small cartilage lesion, I would definitely try a little bit of therapy. If it's a little bit bigger and you're starting to have some swelling in the bone or some other issues that the MRI would show, sometimes those we go in, we clean up, and sometimes we actually take a biopsy of your cartilage, send it off to a lab, and we can actually grow it in a lab and we can replace the area where the cartilage wasn't healthy in your knee. But that's pretty nuanced. So I have to see your imaging to tell you the answer of that.
Thank you. The next one comes from somebody in our audience. Says, I am 76 years old, tore my meniscus 10 years ago, had the mastectomy. It helped, but I have
Yeah, I got
OA.
it. What about
What
stem
about
cell? Yeah,
for
so totally reasonable if the steroid shots and the gels aren't working, then I think a stem cell injection is reasonable. That gets to the PRP. That's what, stem cell PRP, bone marrow aspirate, they're all kind of fall under the umbrella of biologic injections. It's totally reasonable to try that and see how you do. There's no real downside to it outside of the cost.
Thank you. Just looks like we're continuing to get some in. Can overstretching cause a meniscus tear?
It's possible. Sometimes usually it's more for a torque on the knee where it happens. Sometimes stretching could have irritated a tear that was actually already there though. So it may not have caused it, but may have started to make it kind of become symptomatic.
Oh, I have another one that says, hi there, thanks for your presentation. I'm 45-year-old female, had a tear fixed when I was 17. Now I can run, jump, dance, hop, skip, do lunges and squats without a lot of knee pain. What do you suggest?
Yeah, they should now she can't.
Sorry
I
about
would
that.
say
I realized
I would say let me see you in the office so I can take a feel of your knee. A lot of what we do these telemedicine visits and things for people, but I kind of got to get my hands on your knee and see and feel and examine it to give you a little better option. So when you have time, come see me. I'll take a feel of your knee and we'll look through some imaging together and we'll decide what to do.
Wonderful. You have access to this? Can you see these?
Yeah,
I
I do.
can
I
read
can
them
read.
all.
So
But
yeah, I got
either
it's okay.
way.
The next person said they had a tear shaved and had arthritis behind the kneecap. The knee didn't respond really well to the surgery. Tried gel and cortisone, still on crutches after June of 22. That's a long time. Any thoughts on why they didn't respond? It's probably because the early wear and tear behind the kneecap started to get more irritated. And so I would say if the shots that you tried didn't work, we can re-MRI it and see what's going on with the knee. I probably would get some new imaging on it at this point. Let's see. Can you use Synvisc congestions for this? Synvisc is a type of gel, so those are gel injections. So yeah, that's one of the things we can certainly try. Um, had a meniscus tear on my knee, warm to limit climbing. So, limiting what you do from a tear, I wouldn't do. I'm not big into limiting your activity. So I try to treat the problem, whether or not that works with the injections or surgery. I try to treat the problem and not limit you because I'd much rather you be active than have a meniscus tear limit your knee. And so if you have something that's limiting you, I would see if we can't get that better and get you to be more active. Then how much do you do PRP with HA injections? So it's a great question, Carrie. A lot of the data out there right now shows that HA or the gel injections are actually more effective with PRP. Problem is usually cost. So if cost is not a problem, actually doing 3 PRP with gel injections is the most effective thing to treat some of the arthritis. But again, that's kind of person specific and based on cost. And then how long would you wait after cortisone to see if it helps? Usually I wait about 4 to 6 weeks after the cortisone shot to see if it's going to help before we progress on to the gel. Cool. Certainly, if you guys think of more questions, feel free to reach out to me. I'm obviously around and I'm happy to see anybody in the office. I appreciate everybody coming on for the lecture tonight. Thank you very much. I have to go see one of our guys now who's been hanging out patiently waiting for me for this lecture, so we can all thank him. Yeah, so Rachel, John, thank you
Yep.
guys for organizing this. I
Thank you so
really
much, Dr.
appreciate it.
Erickson. Have a good rest of your
Of
evening.
course. Take
For
care, guys.
everyone who's still on the line, just wanted to let you know again, this lecture was recorded, so we will be sharing this with the rest of you folks within a few days. Any other further questions, feel free to reach out to myself or John. I'm always happy to get in touch with the docs, answer any questions. For any that are still asking questions, I apologize. We will make sure to get those questions over to the doctors and go from there. But otherwise, enjoy the rest of your night. We appreciate you taking the time and yeah, enjoy the sunshine, everyone. Have a good one.